um, it inspires you to get trained in CBTs, in particularly the topic of relapse prevention, which is very essential in the treatment of opioid use disorders. I have nothing to disclose. Neither no financial arrangement for the presentation nor any content of the presentation. And this is a presentation that was previously presented by Dr. Lindsay and prepared by the team. And again, the topic is CBT, in particularly geared towards relapse prevention. And hopefully towards the end of this very brief presentation, you'll remember what are the basic components of CBTs, what do we mean by trigger identification, and then management of urge and cravings, and then a little bit of behavioral contingencies and how to use them. So I think with motivational interviewing and other topics, we often talk about the stages of change model, the transtheoretical model that was developed by Prochaska and DiClemente. And it's a great model for the treatment of substance use disorders because it allows us to understand where patients are at, and so that we can be collaborative rather than pushy and prescriptive. I think often it's easy for us to forget that patients come from very different walks of life. And so they might not have the resources, they might not have certain things within their community, and they might not be ready to change. And so that the transtheoretical model can help us in understanding what types of tools can we use. Relapse prevention is definitely one once somebody's in the action, and the maintenance, if I look, there we go. And action and maintenance, because they're already on a steady change. We usually talk about harm reduction at the beginning, right? When they're first starting treatment with us, there's no stability or very little stabilities. One of the main goals is trying to reduce harm within that period. And then as soon as there is some stability, that they're able to continue treatment with us, the ideal type of treatment would be CBT, cognitive behavioral therapy. And then of course, within CBT, there are some relapse prevention skills that can be used. So if you can imagine during CBT, during the 3 stages, you're actually putting in place as many skills as possible when somebody is reducing use. And then once they hit either a lapse, relapse, then they're able to put into effect whatever you taught them in this stage. I think sometimes it's really interesting when we see patients come in. I think I often see it with alcohol. They hit the honeymoon stage, right? Like they're ready to go. And we see it in opioid use too. They're ready to go. Somebody inspired them to change, or maybe they're at a point where they really want to change. They haven't used for a period of time, and they feel very positive about everything. The best thing to do in that spot, in that little honeymoon stage, is to really put in as many CBT skills, because we know lapses and relapses are a natural process in the treatment of substance use disorders. I think in the past, we used to see them as something very negative and as a symbol of failure, both of the patient and very often of ourselves, right? Like we must have not done it right. We must have missed something, which was, I think, a pretty rough approach. So what is CBT in general? It really links thoughts, feelings, and behaviors. There is a lot of evidence in treating addictions of different substances, as you can see here, and it's very, it can be very flexible, right? I don't know if you've ever seen, there's a video of Bob Newhart, very short video, I think from the early 90s, that tries to mock a little bit CBT, where he's trying to say, no, we don't talk about emotions. No, we don't talk about the past. No, we don't talk about, we don't go too deep into things. It's just a very like on the surface, on the present based type of modality. And that is actually not true. So if you think of Aaron Beck, he actually was trained under psychodynamic approach. So there's a lot of psychodynamic, in other words, there's a lot of like, let's understand childhood, let's understand attachment theory, etc. we definitely go into deep things, right? So when we're looking at the connection between thoughts, emotions, and behaviors, very often we discover that some of those are coming from childhood, right? So we have parents that instill very distorted thinking into kiddos. And now there are patients, there are adult patients trying to struggle, trying to avoid, trying to engage in behaviors that are not healthy through substances, right? And in particular, opiates. I think I mentioned to you hearing from one patient, and it really impacted me when she said, using heroin to me is like the world giving me a hug all at once and feeling connected, right? And so great, because for us using CBT, we're able to recognize what is it that she's missing? What is it that she's looking for? How can we find that? She might make connections, but maybe not as quick as the heroin shot, but definitely connections that are long lasting, that produce less negative effects. So again, being able to recognize what are those thoughts and why she's seeking that emotion and the behavior that she engages in, which in this particular case is using heroin, and how instead of that, we can put things in place, including the environment. So we'll talk a little bit about triggers. It's pretty interesting from the CBT perspective. In a session, they're highly structured, which I love. You start with your agenda, so your patient knows exactly what you're going to be talking about for the session. You invite them if they have something that is, so again, it's not rigid, but it is structure, and there is flexibility within that structure. So you ask your patient what are some things that they want to bring up, put it in the agenda, and try to see where it best fits in the session. You have 20 minutes of the session, and you review within those first 20 what happened in the previous sessions. In terms of assignments and things that they had to practice. The idea is if you only practice something new during 1 hour session once a week, it's not much of an impact as compared to them practicing at least 1 hour for 7 days, and then the time that they see you, right? And of course, if they practice more, the better. How many of us are willing to change things, right? The reality, even in interviews, right, in job interviews, people often say, oh yeah, no, I'm comfortable with change. The reality is we're not. As humans, we really are not comfortable with change, but there are ways to manage it. So now imagine when it comes to substance use where there are really strong connections. There is a lot of empathy and acceptance. There's a lot of encouragement in sessions. And then what you're trying to do is, again, trying to avoid being passive and rigidity, right? Like, again, the stereotype of it. So as I mentioned to you, the first 20 minutes, you're setting the stage, you're reviewing any homeworks. CBT loves to use measures, nothing like having an objective measure to help you. Very often we think our patients are doing much worse. And once we have measures, they actually help us realize where they're doing their best, what are some things that we can rely on, and then what are some things that we need to work on. And then in the next set of it, as I mentioned, is when we start introducing any new material. That includes role plays, right? So we might have somebody saying, haven't seen mom. Mom always makes me want to drink, or mom always makes me want to use. And we can role play during the session, right? What would it be like to go see mom, right? Who may not understand how to be supportive. And then the last, which is very important, is checking for understanding, right? Did they understand what we talked about? Sometimes I'll ask people, well, what would be one thing that you're taking from today? What's something that was shocking for you today? And then we also, if we're sending them with practice assignments, we want to know that they understand, right? So if we're having them practice, one that I love to teach them is the catch it, check it, change it with compassion, is the C4. I have them practice it in session. Okay, let's catch it at thought. Let's check it, let's evaluate it. Is there a distortion in that? Is there something that is unbalanced? Okay, it sounds like there are some things that are not very balanced there. So how can we change it? And then, of course, with compassion, how can you be kind to yourself as you realize you're doing the same thought that we've been talking about, or maybe it's a completely new one, right? Very often they'll say, oh man, of course I had to do that. I'm so dumb. It's like, okay, that's not with compassion. So we'll go back. Some challenges. Remember the focus is trying to recognize those thoughts. There's certain populations that this might be a little bit difficult. You can definitely simplify it. There's CBT that's used with children. So there are ways to simplify CBT. The clinician may have to problem solve if they cannot do some of the assignments that they take home, and then reframing to fall into old patterns. Most people that I train in CBT will tell me that it's really hard to set an agenda, and it's so easy to just go into like checking in and talking about other things. Repetition is super important, right? If you think in terms of substance use, it is a habit, right? Like you start with the trigger, the thought, the looking for the substance, getting the substance, using the substance, and it goes all back again. And it's just such a connection between those that we're trying to break pieces of that chain, right? And so, and the only way to break them is not just a one-time in session aha moment, but instead having assignments and practice homework. I hate calling them homework assignments that they can do during sessions. I mean, in between sessions, right? So they're practicing over and over, including recognizing what might be some triggers, because very often many patients don't even know. It's been so long that they don't no longer understand it, right? We have many patients that will tell us they're using now so that they can avoid the withdrawal symptoms, but then we can talk about that, right? How did it get started in the first place? How is it that it is like that now? Very clear rationale, right? Why are we doing what we're doing? We constantly are explaining in session. So today we're going to do a function analysis. This is what a function analysis is, etc. Praising approximations and using like the MI model, being sincere about our praises, not using so many praises that it sounds so not really not something real, right? Not something sincere. But definitely, if there's an opportunity in between sessions that we missed, to be able to talk to them about what is that they're doing well, right? So when we talk about breaking that chain, we talk about classical conditioning, right? So this chain is so strong, right? The thought, the craving, and use, thought, craving, and use, that we're starting to break it at any piece of that chain, right? If you think of classical conditioning, the overall story of it is there are times where we link things that should not be linked. And in this case, with our patients, what has been linked is not the substance itself, it's just what has been linked with the substance. It could be that corner store, it could be certain people, it could be every time they feel sad, right? So it's something that we talk about in CBT, especially as we're reducing harm and then moving into relapse prevention. So we want to know what are the environmental stimuli that are affecting the patient. So I mentioned to you just briefly, one of the things that we do within CBT, especially for relapse prevention, we also do it at the beginning in harm reduction, is this famous function analysis, which is a fancy name for an analysis of why we do things. Why do we function a certain way? What's really interesting about this function analysis, when you sit and share this with your patient, of course, it helps us to understand when they're feeling the strongest need to use. But what's really interesting about it is when we talk to patients, most patients tend to be very surprised by the long-term negative consequences. It's the immediate reward makes it really difficult to understand and even see what they have been and how costly they've been. So this is to the patients. On a side note, for families, when we use this, the families tend to be very, very surprised about the short-term positive consequences. Very often, they don't understand that their loved one might be using because they don't want to feel sad anymore. They don't want to feel the effects of PTSD. They don't want to experience pain anymore, and nobody is listening to them, and they're not wanting to manage, and everyone keeps telling them how they are just crazy because they treated them for everything, so it is not possible that they could be experiencing pain. right? So, so this part is very interesting for the families. This part right here is very interesting for the patients, and it opens a great door for communication with us providers and them in terms of, well, what are some things you would like to change? What are things you feel you could change? Behavioral contingencies is another approach from relapse prevention, CBT relapse prevention, in which you are, oops, I went a little too fast there. Let's see, I apologize. Let's see, let me just make sure. Yep. Okay, so so we look at research. Remember that famous, it wasn't all of our boards exam, that for 2x2, right? So you have rewards and you have punishments. Rewards are things that increase a behavior. Punishments are things that decrease a behavior. And research shows time and time again, the one quadrant that increases the most behavior and it keeps it for the longest period of time is a positive reinforcement. What does that mean? Increasing a behavior through giving something. The one that works the least is punishment. Both of them, both of the quadrants are not. You will have change, right? How many of us do reduce speeding when we see a cop, right, on the road? We immediately change our behavior. Now, how permanent is that? Once you don't see the cop, then you increase your speed, right? So, so the best way to increase behavior is positive reinforcement, which can be really rough because it sounds to some people, the comment that I always get from families is like, wait, what, are you saying that I should reward them for using? And so that's a misunderstanding. It's rewarding them for not using, for the behaviors that you want to see in them, right? So in craft for families, we talk about rewarding them when they come home and they haven't used. Rewarding them when there isn't anything around, or they've done behaviors that are good and helpful for them. Maybe depression is one of the triggers, right? And so they're taking their meds for depression, rewarding them with something for that. Okay, here are some examples of reinforcers, positive reinforcers or rewards. They can be vouchers, privileges, opportunities to win a prize. If you come to ASAP, we as you come in, we have this large glass display of different things. If you ever want to do contingency management, you want to really you can ask us, or you can ask other people who train in this particular modality, because you really want to find out, for example, what is it that your participants want, right? We bought things that we thought patients would like, and we were very wrong. So things that were super popular, bus passes. We didn't even think of that, right? So being able to understand what are things that people want. So variety chips are still very important. So attendance can be, so for example, here ASAP, you'll see patients that participate in so many, that participate in group, individual therapy, walk-in, they go to the doctor's appointment and they're accumulating points, and they can wait so that eventually can get a bigger price, or they could just right away trade them for, say, a bus pass or something else. I think they have a monthly pass. So if you wait long enough, you can get a monthly pass. So definitely they work. Another one would be alternatives to use, right? So in CBT for relapse prevention, we talk about, let's actually write down and go a little bit to troubleshooting as to what would you want to do if you all of a sudden have an urge, if all of a sudden you have a thought about wanting to use, right? And so we even talk about the barriers to that alternative, just in case. Another one would be urge management. So if you remember that list, so they have the thought, they have the urge, and then the use. So if we can stop at urge, we know that urges only happen, like the highest is about 20 to 30 minutes in time. And so if they can record what are some things that they can use within those first 20 minutes that feel like an eternity, what can they do? Who can they call that is safe? And then they have it, that's something that they have for themselves. Here's an example of one. And then here's another approach, which we just talk about, can we just serve the urge, right? So you understand that it's 20 to 30 minutes, but then after that, it will pass. Can you do distracting activities? Can you do certain things that just you're observing the urge coming in, you feel it, but you're not acting on it. You just like the wave, you actually ride it. So that's another approach. Another one that I love is high risk situation planning. We do this for everything else, right? For fires, for other things. Why not for situations in which I really have to show up at the family gathering? There's not much I can do. What are some of my outs? What are some ways for me to actually not engage? I often, and I'm not sure how often you get to hear this, right? When you have patients that say, I'm going to test myself. I'm going to do this to test myself. Not a good idea, right? So we talk about not ever doing that, but again, understanding that there will be situations in which it's very high risk. What does that mean? There are people that use, there are things that remind me of use, right? Syringes, whatever else. And then there's situations that may cause me emotions to use. And so we talk about what are some ways to remove yourself from the situation. We want to make sure, I think it's in our next slide, that we are in as many low risk situations as possible, and really try to reduce high situations as much as possible. There's no testing. So something good to remind your patients, because I think often at the beginning, once they're like kind of getting at the end of the honeymoon stage, they picked up a lot of really good skills from you. They're really excited that they finally are connecting with you. They feel like, okay, I'm going to test it. And that's not a recommendation. So here's an example of a worksheet. You will have, or you should already have, you had the link to the handout. So you're welcome to use some of this exercises. And here's one last one that is really interesting. Develop a plan, a daily or weekly plan. I remember once seeing a psychiatrist who was being treated for, I want to say that bipolar disorder. She's in one of the NAMI videos. And she said, idle time, free time is dangerous time. So it's good to plan, because very often in mental health, in substance use disorders treatment, we know that if we don't know what to do, we're probably going to get in trouble. And so nothing like being able to see what other things can you do during that day so that you don't hit that trigger and then you get into that chain. So this is CBT in a bit of a nutshell. Again, very useful. Definitely has that connection with the emotions. When treatment can vary, right? But it's not a years and years type of treatment. You definitely are addressing specific factors. We do talk sometimes about what went on in terms of childhood. How did those connections get there? What might have developed those core beliefs, right? I am no good. I am a waste of life. I am a failure, right? We really get to that by teaching them how to identify all of these other thoughts with the 4 C's, right? So that's one of the pretty big elements that we have them repeat quite a bit. Very good. I think I did good in terms of time, especially knowing that we have a good update. I don't know if anybody has any questions in terms of any of the components that I just mentioned very briefly of CBT for relapse prevention.